Okay, so we're in chapter 26, digestive system. You guys will have a quiz on this on Tuesday, a lab quiz. Expect 20 questions, I believe, still only worth 10 points, multiple choice. So that lab quiz will be open for you on Tuesday. And Tuesday will also be our final live lecture because we're going to try to get through urinary and reproductive, which are both shorter chapters, on Tuesday night. Because then a week from tonight is your last lab exam, and then your final lecture exam will be June 2nd. So really coming down to the wire here. So let's look at your digestive system. Again, this is one of the more interesting body systems, I think, because the anatomical structures are things you can see and imagine. They're not so small. So some of the functions and characteristics
What are you doing?
of the digestive system are that you use it for ingestion of food, mixing of food, transportation, and breaking down of all food. It also helps to absorb digested nutrients from the food and then obviously expelling any waste. We call that food mixed with saliva is a bolus. So from here on out, I'll refer to any food when it comes into your mouth and gets in contact with saliva, we call it a bolus. And then once it gets into your stomach, we call it chyme. So bolus and chyme. The digestive system has two categories of organs, the GI tract organs and the accessory digestive organs. Your GI tract is one continuous tube. So it's completely connected. It starts with your mouth, it ends with your rectum, and it's one continuous tube. So it includes those structures there that you're free to write under your notes under Roman numeral number 1. And then all the accessory digestive organs under your notes are the answer to question number 2 under your notes. The accessory organs are all connected to the GI tract, but they're not a part of it. So this would include your teeth, your tongue, your salivary glands, your liver, your gallbladder, and pancreas all secrete digestive enzymes into your small intestine to help that break down. But the GI tract, the one long continuous tube, starts with your oral cavity, ends with your anus, and it includes all the structures in between there. So here are on the right side, the GI tract digestive organs. And on the left side are all of the accessory digestive organs. We include salivary glands in the accessory digestive organs. They secrete saliva, which helps to break down the food itself chemically, especially starches and carbohydrates. The liver helps to detoxify everything that you eat, and then the gallbladder will secrete bile that digests fats, and your pancreas there secretes different pancreatic enzymes to help digest things in your small intestine. And then the GI tract, you can see how it's all connected from your oral cavity down through your pharynx, your esophagus. The stomach is the J-shaped sac-like organ to the right of the liver, and then your small intestine kind of curves around. It's small because of the diameter size. So it's a small intestine, and the larger intestine has a large diameter. Okay, so these are some functions of your digestive system. You can write them down in your notes if you want to, under Roman numeral 3. Ingestion, motility, which is movement of that bolus and chyme, secretion of digestive enzymes, whether they're coming from your gallbladder or your pancreas, absorption of nutrients, and then the elimination of wastes. Okay, so ingestion is just the introduction of materials into the mouth, and then the motility is anything voluntary or involuntary having to do with the contractions of your muscles that will mix and move materials through that one long GI tract tube. Peristalsis and mixing are two movements that we'll refer to. Peristalsis is a ripple-like wave of muscular contractions that forces materials to move further. And mixing is a name for like a churning movement where it'll mix up the feces or chyme and then push it forward, mix it up some more, and then move it forward. And I think I have 2 pictures here on the next slide, just telling the difference or showing you the difference between peristalsis and mixing. Peristalsis will occur in your esophagus. So your esophagus has these wave of muscular contractions that'll squeeze that bolus down, kind of like a Go-Gurt. I feel like I use Go-Gurt to describe a lot of things, but it's a good analogy or picture to think of. So that's what peristalsis is in your esophagus. And then the mixing really happens a little bit in your small intestine, but mostly in your large intestine, where things will be mixed, sent back, mixed some more, sent forward. And that's really what will create more of the feces. More function secretion involves release of mucin or fluids such as acid or digestive bile or digestive enzymes. Digestion breaks large food items into smaller structures. And we refer to digestion as either being mechanical or chemical. And mechanical only involves the physical breakdown of the food. So this would include chewing, mastication with your teeth, and chemical digestion breaks down the ingested material into smaller molecular components, and most always uses enzymes that are coming from your pancreas or the gallbladder. Absorption involves movement of these now smaller molecules across your GI tract into blood or lymph. Your lymphatic system is kind of the catch-all system of any extra waste that your blood doesn't pick up. But most of the nutrients go into your blood and they'll go to your liver where they'll further be kind of detoxified. And then elimination involves defecation of indigestible waste products. So defecation is the medically correct term for going number 2, and I'll refer to it as that from going on 2. Okay, so we'll start with the oral cavity. I see number 4 in your notes had to do with the differences between peristalsis and mixing. And now we're already to number 5. So the oral cavity is the initial site for both mechanical and chemical digestion. It's lined with that non-keratinized stratified squamous to help with any abrasiveness from the food itself. The oral cavity boundaries, you have teeth and lips in front, a palate on top, and then your mylohyoid muscle right underneath it. There's 2 regions. The vestibule is between the cheeks or lips and the gums. So that's just the area right between your cheeks and your gums. And the oral cavity proper is anything more centrally located to that. A little bit more about the oral cavity. So you can see how the hard palate, you can see the bone makes up the front kind of anterior 2/3 of the whole top half of the mouth. And the soft palate makes up the back third of the superior portion of the oral cavity. And that soft palate is what will elevate again to close off the nasal cavity so that food doesn't go, or liquid, go up into your nose. You can see your uvula hanging back there, that little boxing, what am I thinking of? Bit thing you hit. I don't know what it's referred to. You know what I'm talking about. The fauces are the openings. You have arches. You can see where your one set of palatine tonsils lie. And you'll also see holes where ducts from some of your salivary glands will empty out into your mouth, which will bring saliva into the mouth to help with the breakdown of starches. Digestive system, you can see the oropharynx here leading to the laryngopharynx. And then you remember again how the epiglottis will close or shut over the trachea so that food will slide back in the posterior esophagus. Okay. Cheeks form the lateral walls. The gingivae are your gums. Keep going there. Gums, cheeks. The palate we talked about, the hard palate forms the anterior 2/3 and the soft palate is in the back. And again, I put a little asterisk here. This will be some sort of text question that the soft palate will elevate during swallowing to close off the entrance to the nasopharynx and the nasal cavity. Okay, so now we'll get to tongue, and there's a couple questions here on tongue. Letter A under Roman numeral number 5 refers to the tongue. has many papilla on its superior surface, some of which house taste buds. So these papilla on your tongue are little small projections. Those are the bumps that you can see and feel on your tongue. Some people think they're your taste buds, but they're actually papilla, small bumps, and the taste buds are actually kind of within the crevices of those papilla. The tongue's attached to the floor by a lingual frenulum that you can see, and there's lingual tonsils in the back. Your tongue really helps with mixing the food and also really helps with swallowing and pushing the food back. So that's your tongue. We'll get to the hardest substance in the body in a second as well. Then we have salivary glands, which produce and secrete saliva, which is important for a lot of different things. It begins the chemical digestion of carbs. With that enzyme amylase, it keeps your mouth clean and lubricated. So my mouth is really dry right now, so that's why I have to keep drinking. It also has some antibacterial power with the enzyme lysozyme. So it just keeps your mouth nice and clean. It also dissolves food, so your taste receptors on your tongue can actually taste it and be stimulated. Your total amount of production of saliva might surprise you a little bit. It's about 1 to 1.5 liters per day, which when you think about it is a lot. It's slightly acidic, but not super acidic because pH of 7 is normal. So it's just slightly acidic. It's mostly made of water and again, made up of this salivary amylase, which helps to break down those carbohydrates. So the 3 pairs of extrinsic salivary glands, that means they're outside of the oral cavity itself. These are the parotid gland, the submandibular gland, and the sublingual gland. There's one intrinsic salivary gland that's within the oral cavity. We don't really refer to that much, but we will refer to these 3 pairs of extrinsic salivary glands. And we'll go through each one. The parotid salivary gland lies right on top of the masseter muscle. You can see where the parotid duct will take saliva that's being created from that gland and empty it into kind of back where your molars would be. The sublingual and submandibular, the prefix sub means below. So sublingual is the salivary gland below the tongue. Submandibular salivary gland is below the mandible. You can also see where their ducts will empty out to bring the saliva into the mouth. And if you're going into dental hygiene or dentistry, they know where these ducts empty out their saliva. And that's usually where the dentist, when you go to the dentist the next time, pay attention to where he puts his little suction tool, and he's putting it right where these salivary glands or their ducts are opening to try to suck out any excess saliva so they can work in a clean environment. Okay, so Roman numeral number 6, the parotid gland is the largest of the salivary glands, but it doesn't produce the most saliva. It's located right in front of your ear on the masseter muscle. So that's the parotid salivary gland. The next one is the submandibular salivary gland. That is the one that produces the majority of the saliva that you need for your mouth. The submandibular duct opens through a little papilla or a hole, a raised hole in the floor of the mouth. So that's your submandibular gland. It's right below or inferior to your mandible. And then your sublingual gland, it's right underneath the tongue, and that contributes about 3 to 5% of your total saliva. So those are your salivary glands. What we're going over now, you don't need to know, but this just shows you what the secretory cells look like. So in histology, we could look at tissue from a salivary gland and see the different types of cells and how what they secrete into their ducts. So those are the secretory cells found in salivary glands. Those are the 3 types. Again, the parotid is the largest. The submandibular produces the most saliva. So you should know those. Okay, the teeth, we won't go into too much here. They're collectively known as the dentition. There's a couple anatomical terms that I can't remember. I think there's a couple on your sheet. The exposed crown is the white part that you can see, and then there's a constricted neck, and then the roots, and we'll talk about what those are. The roots fit into sockets called dental alveoli, and the crown is formed or covered by enamel. And this brings us back to letter B under Roman numeral number 5 in your notes. You should know that enamel is a substance, and it's the hardest substance in the body. So it's stronger than any of your bones that make up your skeleton. So it's a specific substance unique to teeth, and it covers the crown, and it's called enamel. It's a good place for it to be because your teeth probably get a lot of, they need to eat the food and break it down. All right, so let's just take a look. There's a pulp cavity containing pulp, and then a root canal continuous with that. I just want to pull up a picture, and this will make a little more sense. You can see how the crown is the area that you brush and floss between, so that's the white part, and it's covered with enamel. Gingiva are just a fancy word for gums. And then there's the neck and the root part of the tooth. The pulp cavity is in the middle. The root canal is the hollow space within the tooth that carries blood vessels, nerves. So getting a root canal is considered painful because you actually have nerves traveling through each single tooth. So they try to anesthetize that before doing any work with that. Okay, so that's teeth. Really quick on teeth. You have 2 sets of teeth, your baby teeth and your permanent adult teeth. And then the permanent teeth include your incisors. Those are the most anterior. The canines are more pointed. And then working our way back, you have premolars and molars. And each quadrant contains 2 incisors, 1 canine, 2 premolars, and 3 molars. The wisdom tooth is a 3rd molar. So you'll notice when you go to the dentist, they charge you per quadrant. So that's a lot of money to take care of just a couple teeth. How many? 2, 3, 4, 5, 6, 7, 8. I was told to be a dentist to make money by my brother, and I didn't. But I didn't want to look at a mouth all day. Plus, I like teaching better anyway. So here's just a look at deciduous teeth, baby teeth that would develop in the months that they come out in an infant child. Really before the age of 18 months, 30 months, they'll come in. And then if we look at adult teeth, then these are the final adult teeth and the 4 quadrants that they're divided into. You don't need to know too much about teeth. So we're gonna kind of skip over this for now. Okay, so then let's keep working our way down here. The pharyngeal constrictors, so we're back in the pharynx. Oropharynx, laryngopharynx. We have muscles that'll help with swallowing. Let's keep working our way down here. The peritoneum, so your abdominal pelvic cavity is lined with a moist serous membrane. The parietal peritoneum lines the inside surface of the body wall. And the visceral peritoneum covers the surface of most of the internal organs. Organs that are completely surrounded by visceral peritoneum are called intraperitoneal organs, like your stomach, and organs that lie against your posterior abdominal wall, so they lie against the back. So they're only covered by the peritoneum on their anterior side and their lateral sides. We call them retroperitoneal. So those are such as the pancreas and the rectum that lie more in the back. Mesenteries are folds of peritoneum that support and stabilize some GI tract organs. Blood vessels, lymph vessels, and nerves travel between these folds. And I just want to show you some pictures of this. There's 2 main types of mesenteries, the greater omentum and the lesser omentum. And these are almost like aprons of tissue that cover your stomach and your abdominal organs to keep everything in place and just allow for blood vessels and nerves to travel through. So these are what mesenteries are. And I just want to show you a picture here. If we were in the cat, you would see, it's really just cool to see this kind of apron-like structure of tissue covering your abdominal organs. So below the greater omentum, you'll see the small and large intestine, and it just keeps everything in place and provides blood supply to those organs. You can also see here your stomach and liver in a cadaver. So here is the greater omentum pulled back, and you can see how the small intestine is kind of travels within what we call the mesentery proper, that tissue. So again, it just keeps kind of everything compacted and held together. So your intestines aren't just, you know, hanging out in your abdomen. They're really compacted and held together. Okay, a little bit about the GI tract organs and the histology of it, which I don't think I actually asked you too much questions about, but there's different layers, and we call them tunics of the GI wall. Working from deep to superficial, we'll work through this. I'm just going to show you a picture of this. These different layers or tunics of your GI tract are important because they each have a different purpose. So you have a mucosa, which will be kind of all these raised little bumps where food will get trapped and absorbed. Then you have a submucosa layer right below that, where you'll have nerves and blood vessels in that layer. Then you have a muscularis layer. And the muscularis layer is made up of 2 layers of muscles that will either constrict the diameter of the GI tract or push things along. And then the serosa is just the outer layer of your GI tract. So the mucosa is the innermost layer. I'm going to go through these kind of quickly because I don't think I asked you too many questions about them. The submucosa is right below that. It's made of loose areolar or dense irregular. This is where all your blood vessels and nerves will travel through. Then you have the muscularis layer, which will have an inner circular layer and an outer longitudinal layer, which will either constrict the lumen or the diameter and form sphincters. So at certain places along the GI tract, it'll be cut off and it'll be stopped and a sphincter will be formed. And the outer longitudinal layer will shorten the tube. And then the adventitia or serosa is just the outermost layer of your GI tract wall. So remember, when I refer to the GI tract, we're thinking about it's one long continuous tube. And these are just the layers of that tube itself. And depending on where you are, whether you're in the stomach, the esophagus, the small intestine, the large intestine, these layers will look a little bit differently depending on what kind of function they have. Okay, so ordering the tunics, I told you you didn't have to know anything and then I ask you a question about them. If we look at from superficial to deep, the outermost layer of those tunics was the adventitia, and then it went to muscularis, submucosa, and mucosa. And then true or false, the soft palate is anterior to your hard palate. What do you guys think?
Isn't the hard
palate
anterior?
Yes, it's false. The hard palate is anterior. The soft palate is in the back. Good. Thanks, Enrique. Saliva moistens ingested food and helps it become a slick, semi-solid material called what? A bolus. And saliva also moistens, cleanses, and lubricates the oral cavity structures. So just a little review there. The arteries that supply the GI tract, we have our celiac trunk, the superior and inferior mesenteric artery, which hopefully seems a little familiar from your last lab exam. And then there's nerve plexuses, or nerves that supply or follow the same distribution of those arteries. So they'll travel within kind of the area where that artery would travel. The celiac plexus is a cluster of nerves that travels with the celiac artery, and the superior and inferior mesenteric plexus are also just clusters of nerves that travel with those arteries. Generally, your parasympathetic nervous system promotes digestion, secretion, and also motility. And we remembered that from the nervous system discussion. The parasympathetic activity is your rest and digest part of your nervous system. Okay, so let's work our way down. I feel like we haven't gotten very far, but we've gotten a lot of the big stuff out of the way. The esophagus is a tube that ducts your ingested materials from your mouth, your pharynx, to the stomach. It passes through an opening in your diaphragm, and just before it passes to the stomach itself, and it goes right in front of your vertebral bodies. So you remember your vertebra back from the skeletal system, and each vertebral body is stacked on top of each other. Your esophagus travels right in front of that. It has stratified squamous epithelium. The submucosa has a lot of mucus glands, and the muscularis layer in your esophagus has a lot of muscles going from skeletal muscle superiorly to smooth muscle inferiorly. So you kind of start to control the swallowing, but then smooth muscle, it's actually an involuntary process as food gets down your esophagus itself. There's a superior and inferior esophageal sphincter, and I'm just going to point your attention to the inferior esophageal sphincter because I think that's one of your lab exam study items. This is just a ring of smooth muscle at the bottom of your esophagus, and this prevents materials from regurgitating or coming up from the stomach. So here's a picture of your esophagus coming down, and you can see the inferior esophageal sphincter will be right at the opening to the stomach. It's also sometimes called the lower esophageal sphincter, and that will close off naturally so that things from your stomach don't come back up. Your stomach is a really acidic environment, so if you suffer from heartburn and you feel that burning coming up through your esophagus, that's actually acid reflux coming from your stomach getting through this lower esophageal sphincter, so heartburn. Here's a look at the stomach, or at the esophagus. Remember, the esophagus, unlike your trachea, can be collapsed. So you'll see the lumen is really squeezed up on itself too. There's a voluntary phase of swallowing that you control. And then there's a pharyngeal and esophageal phase, depending on where that bolus travels down. And something that always makes me, I don't know, it's interesting to me is that it takes about 5 to 8 seconds for a bolus of food to pass involuntarily through your entire esophagus, which I always think is interesting because once you swallow it once, you think, oh, it's in my stomach, but it actually takes count to 8 seconds before the food actually gets to your stomach. So here's a look at how a bolus kind of gets traveled down through the pharynx into your esophagus. You'll see here how the epiglottis closes again over the trachea. And yeah, so there's your bolus traveling down. Then your stomach is in the upper left quadrant of the abdomen. And again, upper left quadrant, always referring to how it looks in anatomical position. So how it would be on your patient. It continues mechanical and chemical digestion. And at this point, we call the bolus chyme because it's just processed into smaller pieces. The 4 parts of the stomach. So we're finally to another place in your notes to write down. The 4 parts of the stomach are in bold here. So the cardia is the first area of the stomach directly where the esophagus would open into the stomach. The fundus is this upper dome-shaped portion of your stomach. And then your body makes up the majority of the middle part of your stomach. And your pylorus is the end region of the stomach, right before that chyme would pass through this pyloric sphincter, which again, a sphincter is whenever the GI tract closes or pinches off to shut something, keep something in. So the pylorus is the region of the stomach right before that chyme would enter into the first part of your small intestine, which is called the duodenum or duodenum. So those are the 4 parts of your stomach: cardia, fundus, body, and pylorus region. And we'll go through those in the notes here too. Okay, so the cardia is that entryway. The fundus is the dome, superior and lateral part. The body is the largest part, and oftentimes the pylorus, we call it the funnel-shaped terminal region. There's a greater curvature and a lesser curvature to the stomach. And I'm just going to go back to show you this picture because I think these are lab terms too. The greater curvature just refers to this part of the stomach on the left side of the stomach, and the lesser curvature would be the smaller curvature of the stomach. Gastric folds, they're also called rugae. The gastric folds just increase surface area for absorption and mixing. So they're little just ridges within the stomach itself.
I'm sorry, you said it's also called what?
Rugae, Rugae. So gastric folds, yeah, you might see it listed as rugae in some parts. There's gastric glands and gastric pits where food will get trapped, and these gastric glands will be secreting different enzymes to help with digestion. Here's a look at the histology of the stomach. These gastric pits, they're lined with different cells to help with secretion that will help with digestion of food. We won't get into this. This is all physiology stuff. There's just different types of cells that will secrete different things. Again, your stomach is very acidic. So a lot of these cells will secrete, for example, parietal cell secretes hydrochloric acid. So the acidity of your stomach is about 2 to 3. So it's extremely acidic. So these are the different types of cells in the stomach wall itself. Parietal cells help to secrete hydrochloric acid. Chief cells secrete an enzyme known as pepsinogen, which helps to, I won't get into that now, but okay. The parasympathetic changes in activity induce secretion of glands and an increase in GI digestive flow. You should know that. And then again, another review, the 3 pairs of salivary glands that are located external to the oral cavity are our parotid, submandibular, and sublingual. So our small intestine finishes up chemical digestion. It's really the place where most of your nutrients are absorbed. So the stomach really hits all your food with a really highly acidic environment, but your small intestine finishes up that digestion portion or breaking down of the food, and it's really responsible where all your food will be absorbed into your bloodstream. Ingested material spends about 12 hours in your small intestine, and your small intestine is about 20 feet long in an unembalmed cadaver. So like a dead person, it would be 20 feet long, but in like someone living right now, it would be a lot shorter because the muscle tone would keep it more compacted. The small intestine consists of these 3 specific regions, and you can write these down in your notes under Roman numeral 8. The duodenum or duodenum comes first. That's directly attached to your stomach, then the jejunum, and then your ileum. So those are the 3 parts of your small intestine in order. So if we look here, we can see a lot of different things, but if we focus on the small intestine first, the duodenum is this little C-shaped structure. So it's the first part of your small intestine connected to your stomach, and it's shaped like the letter C, and it's really only that long. So that's your duodenum. And then we get to your jejunum. It's in purple here, and then your ileum is kind of the other 2/3, 1/3 of your small intestine. Your ileum connects to your large intestine with this ileocecal valve. So again, it's a valve that opens and closes just to allow material to pass through. Ileocecal valve will enter into the cecum, which is kind of this blind pouch or sac at the bottom of your ascending colon in your large intestine. And then your large intestine kind of goes up and around and down. So the large intestine is a lot shorter, but it's called large because its diameter is a lot larger or wider. And the small intestine has a much smaller diameter. Your accessory organs, you can see here, liver, gallbladder, and pancreas will go through. They will all empty out their digestive enzymes into your duodenum, and we'll see that as well. So the duodenum is C-shaped. It originates at the pyloric sphincter, at that pylorus region of your stomach. becomes continuous with your jejunum. And then we have a major and a minor duodenal papilla. And a papilla is just a site where bile and pancreatic secretions will enter the GI tract. So think of a papilla as just like a raised opening where ducts coming from the liver, your gallbladder, or your pancreas will dump all their digestive enzymes into it. The jejunum is the middle part, and the ileum is the last segment, ending in the ileocecal valve, which again will be a sphincter that will open and close to control entry of materials into your large intestine. A little bit of histology. There's circular folds within the small intestine. We call them plicae circularis. They are covered with villi and microvilli. All of these kind of villi or finger-like projections just help to absorb any digested material and transport those nutrients into the blood. So let's just look a little bit about this. Here are the folds or bumpy ridges, also called plicae circularis in the small intestine. You can see how they're covered with these villi, which are the fingers, and microvilli are the little teeny tiny kind of fingers popping out. And this just provides surface area and a space where food can get trapped within these little tiny folds. So all of these cells can do their work, digestive enzymes can do their work, and really that food can get absorbed into these microvilli and down into your bloodstream. Histological view of the small intestine. Again, some of this might look a little familiar back from histology and some of their structures and anatomies. Then the large intestine forms a three-sided perimeter around your small intestine. It has a larger diameter. From here, the material is referred to as feces because it will absorb a lot of water and ions and will do that mixing, compacting motion to try to compact anything undigestible into a smaller part and solidify them into feces. And again, it stores feces until defecation. So here we have our ileocecal valve coming from the ileum. Our cecum is our blind pouch at the bottom of the ascending colon. At the bottom of the cecum, you can see what we have, the vermiform appendix. So it's a little finger-like projection off of the cecum. No one knows why we have an appendix. There's no real reason for it. It can only cause problems if it gets engulfed or inflamed. And for good reason. There's a lot of junk going through your large intestine. So if it gets kind of enlarged or inflamed by some sort of infection and it were to burst, that would just be a terrible place for it to burst in your body because your body's trying to get rid of all this bad stuff, not leak it out into the interstitial fluid. So I'm sure we've all known people with burst appendixes or appendicitis, which is just an inflammation. Okay. So then ascending colon will travel up towards the liver. The right colic flexure is where the large intestine turns into the transverse colon. Colon is just another word for large intestine. So if you hear of someone with colon cancer, they have cancer of their large intestine. Then the left colic flexure will be over by your spleen. And then the descending colon will enter into what we call the sigmoid colon. And the sigmoid colon is just the bottom part that curves up like an S before it travels into your rectum and then the anal canal. The right and left colic flexures are sometimes called the right hepatic flexure because it's near the liver. And the word hepatic always has to do with liver. And the left colic flexure, sometimes known as the left splenic flexure because it's near the spleen. What else? The last thing about the large intestine is that some people actually have, I don't think it's the percentage is very high, it's less than 10%, but their large intestine is switched. So their ascending colon comes up on the left side of the body, travels across, and their descending colon goes on the right side of the body. Not a huge deal unless someone does have appendicitis or a burst appendix. They'll make sure that their large intestine might not be flip-flopped around. Okay, So here are the following structures in order. So this takes us to Roman numeral 9 in your notes. And I think A, B, C, D, E, F, G, H, I. I think I added in the hepatic flexure and splenic flexure, but you can kind of fill in the following structures in order as we go through: cecum, ascending colon, transverse colon, descending colon, sigmoid, rectum, and then anal canal. So I kind of quickly talked about these already. How the cecum is the first part. It's the blind sac. It has the appendix projecting down from it. Then your ascending colon travels upward, makes a 90-degree turn by the liver, called the right colic flexure, and then that enters into the transverse colon, which travels transversely across the body, which I learned during pregnancy. All your intestines get like spread out, and I don't know, it's weird. I'm ready to be done being pregnant. I don't. So your transverse colon then travels transversely across, makes a 90-degree turn inferiorly. We call that the splenic flexure, the left colic flexure. Goes into the descending colon, and then the sigmoid colon again is that little shape of an S. So your colon kind of goes down and up before it heads back down the anal canal. The rectum and the anal canal. So the rectum is the muscular tube that readily expands to store any accumulative waste. There'll be valves that will help control that. And then the anal canal are just the last few centimeters. So it'll end in sinuses, and there will be sphincters that will relax during defecation and help to eliminate that waste. One other thing about the large intestine, it has muscles traveling along it called the teniae coli. And I'm going to go back to the picture to show you what this looks like. But the contraction of these teniae coli muscles, they bunch up your large intestine into many sacs, and that's what we call haustra. So the teniae coli is just a muscle that helps to form bundles within the large intestine, and that just helps with mixing of the fecal material. And I just talk about those two because those two are other two lab ones. So you can see this kind of lining, this white lining that travels within the large intestine. That's just a thin kind of line of muscle, and we call that the teniae cola or tenia coli. And it'll help bunch the large intestine into haustra. And one haustrum is just one kind of segment or bunch. So this will kind of bunch up and help the mixing process of the feces. Okay, there's a lot in this. Normally this takes a lot longer if we were in person, so I know you guys are doing great. I'm gonna move on to, this talks about how it churns and moves. So the haustral churning, this is just the movement of the feces through the contractions of the muscularis layer. Okay, so let's get into some accessory digestive organs. It's easier to drink out of a straw. Sorry, I have my sparkling water. I've been living off sparkling water because that's the only thing I can drink. Not that I'd be drinking a lot of anything alcoholic, but okay. So here we have accessory digestive organs, and we'll finish with this: your liver, gallbladder, pancreas, and the biliary apparatus. So we'll talk a little bit about these influence digestion. Your liver is composed of 4 separated lobes, your right and your left. And then we have subdivisions of the right and left called caudate and quadrate. The round ligament of the liver is a remnant of the umbilical vein during development. And it's the remnant of a vein because it'll take all the blood that you digest and detoxify it. Okay, along the inferior surface of the liver, we have another remnant of some embryonic ductus venosus. So anything venous or vein related will end up in the liver because your veins will take all the blood, carrying everything absorbed from the nutrients of your food to the liver to be cleaned out. Your gallbladder is also there, and will have a porta hepatis where everything enters and exits the liver. here we have the liver, a right and a left lobe. Again, right and left for how it would sit in a patient. Your gallbladder, you can see a little bit better on the underside of the liver itself. The gallbladder itself just stores bile. So your gallbladder will store bile that the liver creates. So the liver will create this bile, this substance that helps to digest fats, and then the gallbladder just stores it. So many people live without their gallbladder, and that's fine because their liver is still creating the bile that it needs. You'll also see here where arteries and veins enter and exit, with the inferior vena cava eventually taking all the cleaned blood. So the liver takes blood in from your digestive tract through the hepatic portal vein. It'll detoxify the blood, get rid of anything bad that you might have ingested. So think drugs, alcohol. And then the inferior vena cava is an important part of this because the inferior vena cava will take all that clean blood then back to the heart. Okay. So your portal vein, hepatic portal vein, carries nutrient-rich blood from your GI tract, capillaries, spleen, and pancreas to the liver. The hepatic artery carries oxygen-rich blood to the liver because all liver cells need oxygen. The word hepatocytes have to do with liver cells. I'm not going to get too much into this. Hepatocytes will produce the bile, and I just want to show you a picture of what this looks like. So within this liver, we have what we call these triads. You can see anything in green carries bile, but all of these hepatocytes, which are these teeny tiny cells, will actually create bile. And the bile will travel into a little bile ductile and eventually go into the gallbladder. But here we have blood coming from your digestive organs. So we call it nutrient-rich blood. And then it'll get detoxified through all these hepatocytes. And then it will eventually travel to the hepatic vein, to the inferior vena cava, to go back to the heart. The hepatic portal system itself is this whole system of bringing nutrient-rich blood from your GI tract organs to the liver where it gets cleaned and back to the inferior vena cava. Okay. I'm gonna go over, let's see, I'm gonna skip over this for now because I think you can all answer these on your own. And the first question we haven't talked about yet, so I wanna come back to that in a second here. Because there's a lot of anatomy, and some of this anatomy is on the final part of your notes. So this picture you'll see in your lab quiz, in your final lab exam. So you should be able to label most everything in this picture. So we're gonna kind of go over that as we talk about these things now. The gallbladder, it's attached to the inferior surface of the liver. And I think your last question in your notes is, what is its function? And the only function is to store and concentrate the bile. And the cystic duct is the duct that's connecting the gallbladder to your common bile duct. So in this picture of your notes, the gallbladder is number 1, and the cystic duct is number 10. And I'll just show this picture in a little bit, but the cystic duct will connect the gallbladder to the common bile duct. There's 3 regions of the gallbladder that I won't really ask you to worry about too much, but a little more about this duct system. And I just want to try to get to a picture before we talk about it. So I'm going to show you this picture. These are the left and right hepatic ducts. They are carrying bile from the liver that the liver created they'll form a common hepatic duct. So in your picture, number 3 is really looking at the left and right hepatic ducts, and they'll eventually form one common hepatic duct. And that bile that's formed in the liver will travel up through your cystic duct to be stored and concentrated in the gallbladder itself. So we have left and right hepatic ducts going to the left and right lobes of the liver. They join together to form a common hepatic duct. The common hepatic duct and your cystic duct join together to form what we call a common bile duct. And the common bile duct is seen in number 2, and it will carry then all bile that's either made in the liver or stored in the gallbladder through what this papilla is. So again, I call this papilla kind of a raised bump or opening in the duodenum. So this is your duodenum right here, and the common bile duct carries any bile from your gallbladder and liver into the duodenum. The common bile duct will actually meet up with your main pancreatic duct. There's also an accessory pancreatic duct that goes through what we call a minor papilla. Don't worry too much about that, but the main pancreatic duct, which whenever I refer to a duct, it's some sort of tube or funneling system. The main pancreatic duct carries digestive enzymes from your pancreas. So just knowing this duct system and how things are separated out in anatomy, you should know. Sorry, I'm just seeing some chats. Oh, that's a good question, Erin. I would refer to 1 or 2 as, just the gallbladder itself. I wouldn't ask you for stored bile.
So both of them will be just gallbladder?
Gallbladder, yeah. I won't go into that much detail. Just know what, the gallbladder is. Okay. Good question, though. Any other questions about the duct? So 10 in your picture is cystic duct, 3 left and right hepatic ducts, 4 common hepatic duct, 5 is the common bile duct, 9 would be the main pancreatic duct.
You said main?
9, 9 is the main pancreatic duct.
Okay.
7 refers to the pancreas. Number 6 refers to the accessory pancreatic duct, which you guys don't need to know. 11 refers to the duodenum. 12 and 13, I would just call that the major duodenal papilla.
For 12 and 13?
Yeah, because 1 refers to like a sphincter on the outside, but you don't need to know that. It's referring to the major duodenal papilla. Number 8, don't worry about number 8. I think it's showing how the duodenum will lead into the jejunum then.
What was 6 again?
6 is referring to your accessory pancreatic duct, but I won't ask you about that. Okay. Yeah, so just knowing that picture, I use that picture for some testing purposes.
The picture that you have on our
on your notes. Yeah.
Can you tell us which ones you'll ask us so I can put a star or no?
Well, we know it won't be number 8. She said no number 8 and
no number 8. Okay.
No number 8.
No number 6, I think she said, right?
No number 6.
Okay.
Number 1 and 2 just refer to the gallbladder.
Okay, perfect. Thank you.
12 and 13 are the same thing too. Yeah. Okay, great questions. We'll kind of finish with talking about the pancreas then. It has endocrine and exocrine functions. What that means is that it has hormone functions as well. So endocrine has to do with hormones. So it helps to secrete hormones and also digestive enzymes. So the main hormone it secretes is insulin and glucagon, which has to do with diabetes. The exocrine functions are what it will secrete through that duct into the duodenum. And that is all, we collectively call it just juice, pancreatic juice from the pancreas. Then those are the enzymes that help to digest things. A little bit really quickly about diabetes, insulin and glucagon. You either have type 1 or type 2 diabetes. Type 1 is an autoimmune where the body attacks the beta cells of the pancreas, which produce insulin. So type 1 is something you would see in young children. You could be born with this. This could lead to little or no insulin formed. So you'd have to take insulin injections or shots or pills. Type 2 diabetes is more what your lifestyle factors will increase your risk of. This is where nothing's wrong with the cells, but because of lifestyle factors, these cells of the body become resistant to insulin. So your cells no longer will respond to insulin, lowering the blood sugar. So glucose then will build up in the bloodstream, or it can totally crash, and lifestyle factors can increase type 2 diabetes. Okay. Let's see, there's your pancreas. This is another good picture of some of these duct systems. If we're dissecting a cat, the pancreas looks like ground beef. And kind of in humans, it's similar. It's kind of has this like grainy texture to it, or the sole of a foot or a boot or a shoe, I mean. So that's the pancreas. And again, you can see where the pancreatic duct will join up with a common bile duct, and they'll both enter the duodenum at the same place, that major duodenal papilla. Okay, so how does your digestive system change with age? Oh, we're gonna get done right before an hour. I was trying to go fast. Your digestive secretions decrease, whether that's mucus secretions decreasing, which will diminish chemical digestion, so your body isn't absorbing the nutrients as well as it should be. Epithelial cells are replaced more slowly. The thickness of smooth muscle of your GI tract decreases. Going to your teeth, periodontal disease and teeth loss could occur. So everything's kind of just falling apart a little bit. It's also accompanied by decreased olfactory and gustatory sensations. And that's it, I think. So stop the recording there.